Aloha, everybody. I'm Chris Leatham. Welcome to The Economy and You. And today's guest is Ken Johnson. Today we're going to focus a little bit on the area of medicine. And I think I'm going to do a couple shows, 2 or 3 shows on this topic because it's an area where Hawaii, I think, needs to continue improvement. We've done a lot of great things, but it's also an area where we've had some unique challenges. So today I brought on a guest, Ken Johnson is an Aprn, which stands for Advanced Practice Nurse. Welcome to Think Tech Hawaii.
Thank you. Welcome.
Thank you
for having me.
Yeah, thank you for being on the show today. An advanced practice registered nurse came about a few years ago, as I understand, because there was a limitation of doctors serving the neighbor islands. And maybe you could sort of give us a brief rundown on what an Aprn does and sort of how the whole thing got started.
Okay. Well, believe it or not, there's actually a long history of advanced practice registered nurses. Approximately about 150 years to be exact.
Wow.
It goes as back as far as the Civil War. And I think one of the first things that APRNs used to do was in the area of anesthesia.
Oh.
And the lady who gets credit for that is Sister Mary Bernard. And she worked at St. Vincent's Hospital in Erie, Pennsylvania. So this is around 1877. She was considered the mother of anesthesia.
So this is post Civil War, or?
This is about during that time, about post Civil War during that time. So, I mean, the landscape or the relationship between nurse and physician has kind of changed over the years. The way we know it now wasn't always exactly that way.
Okay.
Nurses were actually kind of independent in and of themselves. But during that time, physicians would concentrate on the surgery itself. Wherein the nurse would be the APRN would be the one actually doing the anesthetizing. Oh. So it's been a very interesting. A lot of people, actually don't know that, but it's a pretty historic profession to be in.
Well, an APRN sounds like initially, if they were an anesthetician, that of course is a field that has changed and has some history behind it as well. I think the first anesthesiologists were people with big rocks.
Yeah. I would have to agree with that one.
And then dentistry probably applied some. I think during the Roman eras, people, of course, would rather commit suicide than go to the dentist. So, dentists weren't exactly the most popular people in town.
Right.
Because they didn't have great anesthesia back then.
Right. Well, yeah, medicine changed dramatically because there was a time when you went to the hospital, it was probably to pass away. It wasn't the place you wanted to go to. So you still have a little bit of the eerie feeling of people wanting to go. But in terms of the question that you asked, and just to get back to that, the APRN, since they have been around for a long time, there are 20 states currently where APRNs are independent. Hawaii happens to be one of those. And when I say independent, meaning they don't have to work under a physician per se. They can have their own medical practice.
So, okay. So they can set up their own office, have their own staff, and service the people in the community.
Right. The other thing, so for instance, like I'll get asked sometimes when I introduce myself, I'm Ken Johnson, I'm an advanced practice registered nurse. People usually lock in on the RN part because they're used to hearing that.
That's right,
RN.
of course, yeah.
But the advanced practice, they don't necessarily know what that means. So they'll say, so you're like almost a doctor. So the other thing you have to think, well, what exactly does doctor mean? Is defined as someone who teaches, right? An educator. You get the highest education in your field. Believe it or not, APRNs, many of us are doctors as well. But we're not doctors of medicine, we're doctors of nursing practice.
Okay.
So in order to be an APRN, you have to be a master's prepared or a doctorate prepared nurse. And that's what gives you the additional training, which is more medical based now, where you can diagnose, treat, and prescribe so that you can manage the care of a patient. Whereas an RN, you don't do a lot of diagnosing, treating.
That's right. Sort of RNs, you sort of do what the doctor says.
You manage the orders.
The physician says, go do this. Yeah. You do that.
They put the orders in, and you go and manage those orders, and you give them updates based on if it's effective or not effective, and they adjust the plan accordingly. As an APRN, now you're going into the role where you're combining medicine with this nursing side of it, and you're combining it into one.
So you're much more of a diagnostician.
Well, you do everything. You can do all of it. Okay. Yeah, diagnose, treat, and prescribe. Now, physicians are amazingly good at that because that's what they do. They go through school. Their whole schooling is predicated on diagnosing, treating. You get the numbers, they get the data, and based on research, experience, they come up with most likely diagnosis, and then they treat it accordingly. So when they get done with their medical school program, they go through a residency program.
That's right.
Which is, that puts them right in the forefront of doing medicine. They're actually MDs at that time, so it's no longer like a college setting. They're not in college anymore.
And it's a 2 to 4 year depending upon the
Depending on what it is, it could be even longer than that. It could be, especially if they're a surgeon, it could be, 5-year residency.
Wow.
The RN path, because we don't do surgery, that's the one thing we don't do. There's some small surgeries that an acute care nurse practitioner can do. That's the other thing, we have so many APRNs, right? APRN covers all of us, but some of us are more specialized in certain things, like acute care nurse practitioner will be more like in your Queens Medical Center,
right,
and an ICU setting.
I see.
And depending on what setting they're in, there's some minor kind of surgery they could possibly do, but surgery is pretty much left for our physicians.
Now, how long has Hawaii had how long has an APRN been allowed to be an independent provider?
Now, that actually has been over the last, I would say, 6 to 8 years. And what it was before, it was, it could be even longer than that. It was that we've had APRNs for a long time. If you came from another state, say like Oregon or Washington, they've been independent for a very long time.
Right.
You had your prescriptive authority, you've been practicing independently. When you came to Hawaii, about 8-10 years ago, you would have to have done another 1,000 hours to get that prescriptive authority again.
As working in the medical field.
Working here, right?
Okay.
Even though you had it in your previous state. So it's like you almost had to take a step back to get what you already had, just coming here. So now it's changed. So immediately once we pass our board exam, you are now given that prescriptive authority right away, which is what allows you to prescribe medications.
So that does a lot in terms of your ability to service the community where you live, and remove that sort of dependence on a general practitioner, which is often sort of that first, that initial consultation. If you have a cold or a flu or you're not feeling well, you sort of go to your primary care provider.
Right.
And so you sort of act as that primary care provider. Is that about right?
Yeah, that's absolutely right. I mean, you, as an APRN, you have the ability to manage and care for, a number of patients. Diagnose, treat, and prescribe, just like your physician counterparts can do that. At the same time, you want to, a lot of APRNs, when they get done with school, will probably go work for a physician, because there's a lot to be gained from that. There's a lot of knowledge to be gained. Because now you're bringing, just a little background. The nursing philosophy in school is this holistic approach. It's this body, mind, and spirit. It's to treat the whole person with the emphasis on better outcomes that way.
Okay. And that seems to be where Obamacare has sort of gone, taken that turn, because it's not just a question of a doctor keeps sort of changing, like a mechanic, they'll keep changing parts until they get it right. Now, there's an expectation as a physician that you're going to get it right more in the beginning, rather than just keep trying things and trying things and trying things. That actually, there's a deterrent to that today. The way you get reimbursed in medicine is that, as I understand it, if a patient keeps having to come back with the same diagnosis and isn't getting treated, you as a physician or an APRN, it's now structured in such a way that you get paid better if you're able to treat the patient effectively in the beginning.
Right, and they call that, it's like pay for quality.
Okay.
So in other words, we want to have a quality care versus this quantitative care, where you got a bunch of patients coming in the office, and you're so booked with patients, and you just get them in there for 7 to 15 minutes, one after another, after another. So now it's like quality based, which is what it should be. We should have a preventative medicine structure, which is the point of really the Affordable Care Act, is to have, I'm going to pay you for managing patient. In other words, their hypertension that they had a year ago should be better now, right? Or their diabetes, it all should be managed better now than it was a year ago.
So long as the patient, of course, is cooperative. You know, one of the challenges that we have is patients aren't always cooperative or willing to modify their diet or their lifestyle.
That's funny you say that. I think that is the big part that we don't always think about.
Yes.
One of the things I think we have to get patients to do, with their help, of course, is you got to own your own health. Your health has to be important to you.
It has to be important to you. And because I travel in different parts of the country, and I noticed a very different dynamic in the Midwest than from the East or the West Coast. I noticed people in the East or West Coast tend to be much more concerned about managing their weight and their diet, and it's sort of reflected in the culture and in the restaurants, even what you get served in the restaurants. I found in the Midwest, there are still meat and potatoes people, and they love a good plate full of meat and potatoes. And size, quantity does matter, so, but yet I noticed too that there's a much higher propensity of obesity. Yeah,
and that, a lot of these things have changed over the years with us. Portion sizes in America are way different than they were in the 50s and 60s. I saw a photo in one of the, because I used to currently work at Queens Hospital. Not currently, I used to work at Queens Hospital. And in one of the ICUs, there was a photo of what a popcorn container looked like in the 50s movie theater versus what it is now. Everything is very large now. So Yeah, we've changed not only medicine-wise, but medicine is adapting to society as well, and vice versa. But yeah, we definitely have some. The focus is going to be more on preventative medicine, and I think where the APRN can help with that is because we do have a shortage of primary physicians. There's just there's just a lot of patients now, and I think by 2025 or 2030, we're projected to be at about 20 to 30% older adults. So that's retired.
Yes.
We're living longer.
Well, we are living longer. Right. The question is, are we living healthier?
Right.
Because clearly, for those of us who try to take care of ourselves, I mean, we all try. I mean, balance is hard to achieve, obviously. I mean, you have times where you're behaving well and you're going and you're working out and you're doing things. Then you have other times where you're just overloaded with work and you don't necessarily get to have that in your life. I mean, of course, you work for it. I think most people do want that. But can we live healthier as we get older? Can we achieve that? In other words, are we just going to live longer but not have that quality of life?
Right.
So it seems that what we are working now at doing is addressing that issue, which I think is great. It really shows I think an intelligent way to address people's health issues today. We talked a little bit about the APRN and the history of the APRN and sort of what you're doing. What is the sort of what do you see or envisage as the sort of the next step in the world of APRNs?
It's a good question also. I think here in Hawaii, because a lot of the communities is probably not used to seeing APRNs in the forefront of healthcare, because people typically think physician first in terms of their care. And I think what it is we do things kind of differently, but kind of the same, because the ultimate goal is to take care of the patient, make sure they get good quality care. So I look at Hawaii, 10 years from now, it's gonna not be unusual to see an APRN practice, on different parts of the state. I mean, there's many APRNs already practicing in a lot of rural areas throughout the nation.
Now, are we benefiting from APRNs in the neighbor islands?
Absolutely. I think Big Island, there's a large group on the Big Island. Even Maui. I mean, we have them here as well, working with many physicians. Not many have their own practices yet. Like I said, it's still kind of a new.
So maybe that's going to be a trend for the future.
I think that
we'll see more APRNs having their own practice.
And then the other thing too is our profession itself is actually now requiring a doctorate prepared APRN, whereas before you could just have a master's. And they're kind of moving out of that master's only. A lot of the college programs now are almost getting rid of their master's program completely. Not completely, it's kind of like underneath this doctorate level program. So they're actually encouraging that.
Okay, well, we're going to take a quick commercial break. Thank you, Zuri, for letting us know that we need to go to commercial. I'm Chris Letha. This is The Economy and You. Stick around. We're going to talk a little bit more about now where the trend is for physicians as well. So we'll be right back.
Aloha, I'm Kaui Lucas, host of Hawaii is My Mainland, here on Think Tech Hawaii every Friday at 3 p.m. We address issues of importance for those of us who live here on the most isolated landmass on the planet. Please come join me Fridays at 3 p.m. Mahalo.
Aloha, welcome to Think Tech Hawaii. My name is Josh Green. I'm the host of a program called Healthcare in Hawaii. I'm a physician. I work in the emergency department on the Big Island. I also serve in the state senate, which, please don't hold that against me, doesn't detract from my television program. We speak about all the big healthcare issues in the state. We get together on Tuesdays from 2 o'clock till 3 o'clock in the afternoon, and we try to talk about the most important issues in healthcare. This is a terrific venue for people to learn about healthcare. There are many programs on this station. We broadcast it later, not just on the internet, but also on OC16. Thanks for joining us. Please be informed healthcare consumers.
Hi, welcome back, everybody. I'm Chris Letha, and this is The Economy and You. Today's guest is Ken Johnson. Ken is an APRN, Advanced Practice Registered Nurse. We've been discussing sort of the benefits of an APRN and how that benefits us here in Hawaii as a community. Ken, again, thank you for being on Think Tech Hawaii. Doctors now, it seems that a lot of doctors are now sort of saying, okay, wait a minute, we have APRNs coming in doing sort of primary care work. That allows more physicians to move into specialty fields. Of course, that means going back to school for a physician. is that, I mean, are we seeing that trend? Are we seeing more doctors
Well, I
moving that
think,
direction?
and I like to say physician.
Physicians, I'm
because
sorry.
we get to be
Physicians, that's
doctors
right.
too. But I would say this. I would say, because it's really hard to speak exactly for them, but what I think they were kind of moving towards the specialties anyway.
Mhm.
You know, it's something they were doing, and a lot of that has to do with, you know, the reimbursement or primary medicine, for whatever reason, may not be what they want to do. There's greater reimbursement in specialties.
It just seems there's a mound of paperwork.
Yeah, and that's what I'm saying. There's a lot of things that
Uh-huh.
could be where, I mean, some specialties you're probably not even dealing with insurance companies directly anymore. You know, so that gets you out of that paperwork loop as well.
Mhm.
So just by I think it's a couple variables in there, and
Mhm.
the fact that we do have a larger, longer living adult population is just not enough primary medicine providers to manage that. So the reasons that they probably, you know, decided to go more specialty is, you know, multifaceted
Okay.
reasons of why they probably do that.
Okay, well, that's good. And the thing is, if we have more APRNs, and it doesn't take as long to get through school, and you can get into place and start working in your field, that also means, I think, for a lot of people who want to be in medicine, they don't necessarily have to go become a physician and have all this massive debt
Right.
that accumulates going all the way through medical school.
Yeah, it's a little cheaper. It's still kind of expensive, but you figure about it, if you did a 4-year program plus you did the doctor, you're probably looking at about 7 to 8 years of schooling
Mhm.
by the time you were done. I think I think the physician's path is similar to that in terms of the 8 years. What they get on top of it is that residency program, which kind of puts them right in the hospital, and they're seeing patients. With the APRN, we don't get a residency program. They're starting to create those. What we get is we're actually on-the-job training. So you're with a provider who's been doing it for a while, and you're kind of with them. So it's almost like
But you're not
intern
necessarily
to-
pulling 24-hour
No,
shifts.
you're not putting.
Yeah, that's just crazy. I
Yeah, you're
still
gonna-
think that's crazy.
Yeah, you're gonna be doing your
Yeah.
normal. You got hired for this amount of time. You're gonna do that. So yeah, it's a little bit better in terms of your sleep.
Yeah.
A lot less sleep deprivation
Yeah,
going on, yeah.
it just seems crazy to me. So now, how does insurance? How are you affected by insurance? I know we've been switching over to ICD-10. That was 2 years and 2 or 3 years in the running until we finally made the switch over recently. So, and then also, with that, most physicians and APRNs now are forced to switch over to an EMR system.
Right.
And I guess that's a good thing, having to switch over to electronic medical records. That means that we can share records between physicians and providers.
I think so. I think
Yeah.
it's a great idea. And, I mean, considering we're in an era now where everything is technology based, we get computers for everything. But I think one thing that you said is important is we can share information. When a patient walks into one office, it's kind of nice if you're a provider that you can see that past medical history about them. It's going to allow you to make a better diagnostic decision in terms of giving them the proper care that they need. Now, we got some folks who've been doing medicine for a while, and they
Yes.
haven't used these kinds of things, so they're a little bit reluctant to want to do that. One,
Yeah.
some people think Big Brother might be trying to come down and spy on them through the computer system. I
Yeah,
guess.
and frankly, some people sort of get into a way of doing things, and they don't necessarily, they're not necessarily amenable to change.
Right.
And so having to switch over to an electronic medical records platform also means that you have to learn the software. But I think again the upside to that, of course, is better medical care. Now, what does that do in terms of cost for physicians? Does that increase their costs?
I think, that's a good question too, because that depends. If
Uh-huh.
there's a lot of, believe it or not, electronic medical record systems that are actually free for the provider, where they don't cost you anything at all.
Oh.
So the question is, well, how do they get paid? So the way they get paid is that if I use their system, anyone that I use that indirectly helps me manage patient care, such as a diagnostic center, labs, X-ray, they'll be the ones that kind of take the cost. But what's in it for them is that you're going to be, kind of
You'll be
directing your
directing
patients to them.
to them
Right.
for, say, blood work
Right,
or
blood work, X-rays,
Uh-huh.
those kind of things. So it's there's ways around it. Now there are some systems, however, that can cost a lot of money for an establishment. Could be thousands of dollars. So yeah, I mean, could be a little pricey.
Yes.
But there are ways around that as well. Now, the
I worked on the transition for the Epic system. I don't know if Epic is a sort of a popular
Epic's
system.
huge.
It's a
Yeah, that's a
it's a
huge
massive system. And I worked on a hospital at the University of California in San Francisco when they were doing their migration over, and we had lots of data that we're taking out of our old system and pumping into the Epic system. And it was a massive undertaking. I mean, it took more than a year to migrate the data over. It was just an amazing transformation. However, and then of course there was all the training for the physicians and doctors and everybody that needed to learn how to use the system. and a lot of frustration, and it was challenging. But at the end of the day, when it's all said and done, I think it certainly has improved the quality of medical care for patients.
I'd agree with that.
Yeah.
Yeah.
Now, cost-wise, I guess, though, I mean, that's still, I guess, as you say, some systems are free, and then it's a
Right.
question of, if you're a physician, what's the appropriate system for you?
That would
Now,
be right.
but all these systems are able to communicate with each other.
Therein lies the other problem.
Yes. No, not necessarily so.
Yeah, not necessarily so. Not all of them will do that.
Mhm.
Some of them do. Like you just mentioned, Epic, which is a pretty big one. A lot of hospitals are moving into Epic. Like I know Queens and Straub have
Mhm.
Epic. I don't know how the other ones. But yeah, that would be the best, all things being even or
Mhm.
perfect. That would be great, because then you would have, no matter where the patient goes, they would link up and you can see this data. But it's not quite that way. I think that's one of the roadblocks, but I think it's slowly being,
Mhm.
dealt with.
Well, we're moving more data into the cloud, what
Right.
they sort of call the cloud, which is really just sort of some place where there's a whole bunch of servers that are running virtual machines and all that
Right.
kind of thing that are storing lots of data on our behalf. And the great thing of course, with cloud computing is it's very secure. It's built around
Right.
a very secure platform. And so our medical data is very well managed and encrypted. And this goes back, I think there was a law several years ago that was passed that required very strict rules about privacy for patients.
Mhm.
And with EMR systems working the way they do, they still allow access, but only to doctors who are given explicit permission. Is that about right?
Right. Yeah.
Yeah.
Yeah, because that's one of the concerns is this information going to be secure? Because
Mhm.
patient confidentiality is very important. So yeah, I mean, it sounds like from my experience with them, EHRs, they have been that way. It hasn't been a problem. There's a lot of security in place to make sure those kind of things don't happen. There's no breach in security or someone else getting access to medical records that
Mhm.
shouldn't have it.
So APRNs are given access. Now you have certain things that you have to acquire, like certain codes or things that you have. I don't know how exactly this works.
You mean in terms of licensing?
Yeah, licensing that you acquire some sort of access to these systems through some sort of a certification or accreditation process.
So once you get your license,
Mhm.
and because every state manages their APRNs differently, like it's not just one, it's different in each state. That's why
Okay.
I could practice independently here. I couldn't practice independently in my actual home state of Florida. So once you get your license, when you go to apply for these things, they already know what state you're in and what degree of
Your education.
privileges that you have
Okay.
in terms of taking care. So it's once you get your license, kind of that door is already open depending on what state you're in. So
Mhm.
it just varies based on the state.
Okay, that's cool. Now,
Yeah.
I wanted to talk about something else,
Mhm.
and I think this is an area in Hawaii that really hasn't, I think, been effectively addressed, is long-term critical care. We have critical care facilities. I know Queen just recently expanded their critical care facilities, but we don't have any facilities here that are built around long-term critical care. And we seem to be growing in terms of our population. We're developing and building more in Kaka'ako and Waikiki and all that area. But the question is, are we accommodating the needs of our population?
I think, well, if you look at it in the acute care setting, like a
Mhm.
a hospital setting, Queens Hospital and Straub, Palimomi, Kaiser, any of those, what can you actually do once you have an overflow of patients? Your ICU only has so many beds.
Right.
There's only so many patients you can fit in there. So you're gonna have to overflow them to another unit to manage that care.
Uh-huh.
Outside of that, if you're looking at a community setting, I don't know. We don't have a lot of long-term care in terms of somebody who's still on a vent.
Right.
If a patient
That's right.
who's still got to be on a ventilator, we don't have a lot of those kind of facilities in place right now.
Mhm.
Some patients will probably have to go to the mainland, and you can imagine all the paperwork that will be involved in that.
Mhm.
But no, we don't have that. And is that something we should probably look at? Absolutely. I mean, because you got patients that are not necessarily ready to leave a hospital,
Yes.
but they can't stay in the hospital.
And they can't stay at home.
And they can't stay at home, right? Because it's going to be right. They're going to need a different kind of care
Uh-huh.
for them. And it's, we got like rehab, Center of the Pacific. That's a little different, right? You got patients that, to some degree, are getting that rehabilitative time, and
Uh-huh.
then they're going to, head home. But for the ones who might be on a ventilator or for a longer period of time, Yeah, we don't necessarily have a lot
Yeah,
here.
when we come back, let's talk a little bit about the neighbor islands and what we need to be doing to improve healthcare in the neighbor islands. I'm Chris Leatham, and this is The Economy and You. Today's guest is Ken Johnson. He is an advanced practice registered nurse, and we're going to come back and talk about our neighbor islands and what we can be doing to improve healthcare there. So stay tuned for more. Aloha.
Okay, this is Think Tech Hawaii, and it's Wednesday. Every Wednesday is Energy Wednesday here in Hawaii, the state of clean energy. 4 to 5 p.m. every Wednesday. Come and listen to us. And just to show you what I mean, I'm going to ask Sharon to tell us more.
Come and see us every Wednesday, as Jay said. And we have people like Jim Albers from HECO here and co-host Ray Starling here every Wednesday. We not only go on Olelo and OC16, but also stream live. So please come visit us, hear about the latest in clean energy.
Okay, Jim, you've been here. You got any comment on all this?
As important as energy is in all of our lives today, this is a great forum and a great format to vet those issues. So I encourage everybody to listen in and participate.
Okay, Ray, what do you think for a close?
Well, I think this is the greatest show in the energy world here in Hawaii. You can come here every week, 1 hour, and catch the latest on what's happening and hear from the people who really know what's going on, like Jim Alberts. We appreciate your coming today.
Thank you.
Ray Starling, Sharon Moriwaki, Jim Alberts, and Jay Fidel here in Hawaii, the state of clean energy. 4 to 5
Aloha.
p.m. Wednesday. Aloha.
Welcome back. Hi, I'm Chris Leatham. This is The Economy and You, and today's guest is Ken Johnson. He is an advanced practice registered nurse. We're going to talk a little bit now about some of the neighbor islands. We've got some challenges on the neighbor islands because we have a shortage of physicians. One of the things I'd heard is that we didn't have anybody on the Big Island, I think. For a while there wasn't anybody there who could treat a heart attack. In terms, there wasn't any cardiologists. Mm-hmm. Maybe there's somebody treat a heart attack. That's probably not the way to say that,
Right.
but there wasn't anybody over there that was working as a specialist in cardiology. And so those folks were having to be flown over here. And I know last week there was a patient that had a heart attack on the Big Island that had to be flown over here, and he was admitted to Queens. So I'm wondering, are we still having those issues on the neighbor islands where we don't have the specialists with the skills necessary to treat people on that island, on their own island?
That's one of the challenges with any rural area is just having the resources or the available bodies or trained persons for those particular specialties in place. I still feel it's true in Hawaii, the Big Island, as it is in a lot of different places where there's just for whatever reason there's not a large population to be taken care of. So yeah, it is a concern still because you don't have those specialists on the Big Island.
Now, how is this, now with an APRN, are you affected by malpractice insurance the same way or to the same extent that physicians are? I mean, is that a big expense for you folks?
Absolutely.
Is it?
Well, and this is the thing too. So the way I kind of see it from my own experience, it depends on what you're actually doing. The more invasive of a practice you have, the more insurance you're probably going to need to have. So I'm family medicine. So my biggest expense, believe me, there's a big difference if I was to get adult malpractice insurance. Like if I just register myself as a nurse practitioner for adults, it's a lot cheaper than if I did as a family. Because family, there's kids involved, and there's a little bit more risk with kids. Everything's weight-based, and they're little people.
Yes.
So, you got to treat them a little bit differently. So there's a little bit more risk. So the more invasive of a specialty you have, the more malpractice you're going to have. So you're probably looking at people that do surgery, anesthesia, dermatology, OB. That's huge.
So now, are APRNs working as doing like baby, like mothers giving birth, and are they working with all that stuff? Yeah.
There's not too many things APRNs don't do. You think about midwifery is actually an advanced practice registered nurse.
Oh, really?
And so there's a couple that I know who do a lot of their births and stuff. People want to go like the more natural way, give birth at home, where they use all the various different methods beyond just being beyond the hospital setting. Yeah, there's an advanced practice registered nurse. So they're actually licensed to do that. Got to have the training and all those kind of things. But because what do you need to know? You need to know when I need to call a physician to handle this case, right? If it's becoming a negative, it's headed towards a negative direction with the birth for breech birth or excessive bleeding or something like that, you
Right.
gotta be able to know who to call. So yeah, APRNs are in cardiology, neuro, dermatology. We're not specialized in the sense that where the physicians are.
Yes.
We primarily have, like for me, family.
Mhm.
We have cardiology programs. We have pediatrics, geriatrics, which is our older adult population.
Right.
And so then if you spend time working with a physician in a relative, a certain specialty, say dermatology, I mean,
Mhm,
you will attain that knowledge,
Sure.
right? So yeah, they work in pretty much every facet of medicine.
See, I think that's kind of cool because then it sort of allows you as sort of moving into an area where you have an interest
Mhm.
or where you enjoy working, and also addressing an area where maybe it's just by the nature of the population you're going to have a higher demand
Right.
to address those types of issues.
Right.
Whether it's for example, diabetes. In parts of our community there are issues with diabetes. In other areas there's issues with cardiology issues.
Right.
Especially for geriatrics. You have, I guess, just a wide spread of issues with geriatric cases. So now, where are you currently operating? Where are you currently working as an APRN?
Well, I currently work out of the Kalihi Kai Urgent Care,
Uh-huh.
which is only been open for a few months now. 2070 North King Street. Actually, it's been I kind of do part-time there,
Okay.
and I've really enjoyed it. One, because it kind of gets me close to what I was kind of doing before. I worked ICU
Okay.
when I was an RN before I went back to school and became a nurse practitioner. But because you never know what's going to walk through the door.
That's right.
So it's like
Right.
it's like a mini kind of ER kind of setting. But I worked there and I enjoyed a small staff.
Mhm.
And I think it's in an area that really needs something like that.
So now with an urgent care, these are walk-in clinics.
Mhm.
You can just walk in. Anybody can just walk in.
Just walk in.
You don't need to set a call, make an appointment. You just show up.
Nope, don't need to call, just walk in, and
Uh-huh.
we're open from 5 p.m. to 9 p.m.
Okay.
The goal is to be open till midnight. So when patients need to come in, because usually most times when you have to go see your provider,
Uh-huh.
it's you either got to take time off work to go and do that,
Yeah.
and then by the time you get off work, they're closed.
That's the trouble. Or you find yourself, your only option is to go to the ER.
ER, right.
And if you go to the ER, you know that's going to be big bucks.
Right.
And you're triaged, so you might be waiting there for quite some time if there's more important cases ahead of you.
Right.
And so if you're sitting with a big cut, but somebody else is coming in with broken bones,
Right.
they're going to get moved up ahead of you.
Or they're having chest pain.
Or having chest
difficulty
pains,
breathing.
right, yes.
And the other thing too is a lot of people end up in the emergency room that really don't need to be there, but
Mhm.
it's the only option that you have at a certain time. So yeah, a place like Kalihi Kai, and we have several urgent care throughout the state.
There's one in Pearl City. I think there's one
Pearl
in
City,
Kailua as well.
Kailua,
Yeah.
yeah. We're one of the, I think we might be the only one that opened up as late as we are,
Uh-huh.
as we do. So it's to give the community an opportunity, and I think where we're located actually is nice for the community as well. They don't have any in that distance.
Mhm. Well, if you're located in Kalihi, that's just sort of central for anybody.
Right.
Yeah. I guess that's good.
A little
That's
bit
a good
easier, yeah, to
location.
get right there. So.
Well, if somebody wanted to go into this field, where would they start? How would they sort of proceed? Now, let's say maybe they're already working or going to school.
Mhm.
How do they sort of get directed in a way so that they move into an APRN path?
Okay. Well, the traditional path, we have a couple now. The traditional path is
Uh-huh.
you would go to school, get your 4-year degree as an RN. Go at that point. From there, you would go actually work in a hospital.
Mhm.
So because that time that you spend as an RN is kind of teaching you, that foundation of what nursing is in terms of care.
Uh-huh.
Especially in acute care setting if you do it in the hospital.
Okay.
And then from there, you kind of get that experience under your belt. You can go back to school and get your master's or your doctorate. Now, do you have to do it that way? No, you can just go straight through and...
Well, is there like coursework for APRNs? It's just a set
Well, once
curriculum?
you get past the undergrad stuff is going to be pretty much the same for any science-based individual. You got your chemistry you got to take. You got your some microbiology, anatomy and physiology. And then you get into the other requirements that you may have because the programs are slightly different, but the science are kind of the same. Once you get out of that...
I heard biochemistry, by the way, was just horrible. Was really
I had
hard.
bio and intro to organic chem.
Organic chemistry,
Yeah, had
that's
to
the other
had
one.
to
That's
do all
a
those.
killer.
Yeah. So once you get past that
Once
stuff,
you get past that, yeah.
and now with a lot of people kind of leaning towards healthcare,
Mhm.
so that's gonna be a little tougher to get in those programs. But so after you do that baccalaureate program and you go into the master's program, Yes, then you're going to get classes that are more geared towards the advanced practice roles, which is
Uh-huh.
going to be your, your medicine-based, advanced pharmacology. Whereas in your undergrad, you took pharmacology.
And you're teaching some of this too.
I do. Actually, I teach at the University of Hawaii,
Uh-huh.
which brings up the other option that people have. We have a program where you could have a degree in another area and then and become an APRN without ever have been an RN before.
Really?
Yeah.
But you still have to do all the
You
organic
got to
chemistry
do
and
all
all the
that
other.
stuff.
Oh,
Yeah.
yeah.
You
the-
can't, there's no way around that. You gotta have to do that no matter what.
You got to do it.
Yeah.
Okay.
And so then you, I teach at UH. I'm currently at Polymomy with a clinical group. So
Uh-huh.
I have about 8 students that I do. I also teach classroom didactic from time to time. I'll do like pharmacology.
Uh-huh.
Was the last course that I taught. It's actually one that I enjoy. So.
That sounds really exciting.
What? Not when I teach it. Not when I teach it. Very exciting stuff. Very exciting.
So where do okay? So now where do people apply? Do they just go? Who do they go see? And like, are there people to go talk to in these? When you want to just go work on this stuff, you go to UH. You go start talking to your counselor.
Like a
there?
counselor. Yeah. So yeah, kind of the same. If you're ready to make that decision and you want to go back to school to be an RN, you can start with there. If you're already an RN, I mean, there's now programs online that you can do also.
So now you're a guy who went into nursing.
Yes.
Are there a lot more gentlemen going into nursing these days?
It's improving, yes.
Is it?
It's of course, as you know, it's a very large female-dominated profession.
Mm-hmm.
But the rate of men getting in the profession has increased quite a bit. When I went through school as an RN, I was usually the only guy in my clinical.
So
school.
for all you guys out there, I just want you to understand that there is a real great ratio of women to guys. So you'll never be lonely. You'll always have somebody to help you with your homework.
85%. That's right, about 85%. Yeah.
That's an incentive, right?
I think so. I think it's an incentive. Yeah.
Yeah.
But it's actually it's and a lot of the females, my colleagues, will tell you that they kind of like having a kind of a male presence, kind of help bring a little balance for many different reasons. But
yeah.
It definitely has grown a lot. When I worked at Queens in the ICU,
That's right.
it was mostly male.
Oh.
A lot of, not mostly male, it was a lot of males working there. Males kind of
So
like that.
you have a mix of male and female drama. So
Yes.
it's not just all female drama or all male drama.
Ultimately brings balance. So that's what you're looking for, balance.
That's right,
Yeah.
balance in the drama.
Got to balance it out.
Well, it was really great having you on the show, Ken. I'm surprised that it's turned out to be a very interesting conversation with you. And this is an area maybe for me anyway. I didn't have a lot of knowledge, and so I'm glad that you came on the show to talk about it because I really. I know that we have a lot of young men looking for career opportunities today, and we have a ratio, unfortunately, in our college system of 2 girls for every guy.
Right.
And to me, that's great for girls, but that also means that we're out of balance.
Right.
And we need to be doing more to encourage young men to move into careers where technology and medicine and other areas as well, because we they have a lot to contribute to this occupation.
Right.
And so again, thank you so much for coming on Think
It was
Tech
a pleasure.
Hawaii.
Thank you.
Yes. And I'm Chris Leatham. This is The Economy and You, and we'll see you again next week. Next week we'll be talking, I think, a little bit more with a physician about medicine and where we're going with Hawaii's healthcare. Aloha.